This session's about crying babies. Unfortunately, I'll let you know I don't have any answers. The last slide is not going to be the cure for crying babies, unfortunately. But it's useful just to get more of an understanding about the patterns of crying in babies, what's normal or potentially abnormal or excessive, what can be the potential causes for unsettled or crying babies, some of the red flags for things about the history or your assessment of the crying baby, and then the last part of the session is more specifically on reflux, gastroesophageal reflux. So that's the gamut of the talk today. I'm very happy if people want to put their hands up or ask any questions on the way. So we usually see babies in clinic who look like that, and the parents say they're like that all the time. And they're always very disappointed when they come to clinic and the babies are like that. So what turns that into that? Unfortunately, that doesn't come out quite as well, but there's been quite a bit of work done on what is normal crying and what is excessive crying, and the rule of threes is something which has become understood as being accepted as excessive crying, and this is quite old data, but babies haven't changed that much over the years, so I think it still applies. And it's the sort of more than 3 hours a day for more than 3 times a week for greater than 3 weeks is deemed to be excessive, and that because it's getting towards the smaller percentage of what's normally seen in crying. And then that sort of brings about this concept of colic, in which it is interchangeable with excessive infant crying, but unfortunately the term colic implies it's something to do with the gut, which there's no evidence that it's anything to do with the gut at all. But people, parents will often talk about drawing the legs up, and often they can swallow quite a bit of wind and things when they're crying. So it's become associated with a fundamental problem with the gastrointestinal system when there's no evidence that is the case. But unfortunately, it's a term that people understand as excessive infant crying, so it remains in common usage. 1 in 6 families can seek medical advice for excessive crying, so it's a common problem, and it causes a lot of distress for families. And there's another paediatrician, Dr. Barr, who again tried to get some normative data to try and find out what is sort of normal, who presents with crying, and then this sort of colicky group as well. And normal babies will cry on average about 2 hours a day. The people who go along to seek medical advice are a little bit more, from the 1.7 up to 2 hours a day, and then this sort of colic group have a mean duration of crying for around 4 hours a day. That's why they use that sort of more than three hours per day. Interestingly, all 3 groups have the same number of episodes of crying, but so the colicky babies cry for longer is the main things, and their cry is more pronounced and they cry for longer. So that's the main point. So the colic group cried for, on average, just over half an hour as opposed to around 15 to 17 minutes. And there were some other characteristics about the crying in the colicky babies. Parents will say, no matter what I do, you can't get the babies to settle. And all kinds of different methods, putting them in the back of the car and driving around the block for an hour. And lot of movement there, trying to, you know, jiggle the baby, and there's lots of different devices to try and keep the baby moving to see whether that helps soothing. And parents talk about, you know, there's a different sort of cry that the baby has, as if it's in pain, and it back arching, passing excessive wind. Some of the bringing up of wind is because they're upset and crying, and so they swallow more air, and then people think it's because they can't bring their wind up, in inverted commas, but I think that's, you don't make gas in your stomach, it's swallowed gas. So whatever wind is in the stomach has been swallowed. So it's a product of the unsettled behaviour. I think it just in response to discomfort, babies will pull their legs up. So I think these are some of the reasons why it's been associated with the gastrointestinal system. And there's been some work done on, you know, because people say that the babies are in more pain than other babies. So they've actually done some studies looking at videos of the facial expressions of babies and try to see whether there's any difference in the appearance of the babies in response to pain. And so there's some of the facial characteristics. The mouth squares off, the eyes are squeezed, the sort of furrowed brow. And they've developed some scoring systems, and when people can independently look at the facial appearances, and the colicky babies do seem to have more apparent facial change according to these criteria. And the other interesting thing more recently was we used quite a bit of sucrose for relief of discomfort in the neonatal unit, for, you know, putting IVs in or getting heel prick bloods done. And there's good evidence that if you give an infant some sucrose, that you will get some more sustained analgesia. And so that's just a graph. It's quite a sudden onset after you've given the glucose, and there's reasonably sustained effect of analgesia with glucose. But what we see with the colicky babies is that they very quickly return to being unsettled, so they don't have that sort of more sustained response to analgesia. So there seems to be something sort of different biologically that's happening with these colicky babies. There was this study in rats which they found that the normal prolonged response to glucose is blocked by naloxone, which is an opioid antagonist. So the concept that it's an endorphin, that being given some glucose releases a brain endorphin, which then results in analgesia, and that the colicky babies have a slightly different response. And unfortunately we do see a number of babies whose mums have been on methadone, and those babies are a lot more unsettled and scratchy and irritable. So that would be in keeping with some change in the sort of endorphin response, an opioid response in those babies. So the other important thing about babies crying is the pattern of crying over time. And usually people are lulled into a false sense of security by their babies being quite settled in the first couple of weeks of life. You know, they seem to just feed and sleep, and then suddenly around 2 or 3 weeks of age, some of them turn into very grumpy monsters. And so why there's that initial 2-week quiet period is a little hard to know, but I think this is a very important graph to have in your mind, so that when you sort of counselling families with crying, grumpy babies, that you can say that, you know, they're likely to be settled in the first few weeks, then they'll start crying, and that the peak of crying happens in that first sort of 6 weeks, and then they will gradually settle, and usually by 3 to 4 months that the crying settles. So it's this is the sort of danger period for you know, parents and families just getting, you know, tired and frustrated and worn out by their crying baby. But if you can sort of describe this pattern to parents, that can be, you know, a very useful and powerful thing to do, and reassure them that it is going to end. And interestingly, there's a similar pattern for premature babies, that it's 2 weeks corrected age, or not 2 weeks after they're born. So it's related to the maturity of the brain as well, and the infant. And unfortunately, that's, you know, often around, you know, the extreme prems will often go home around 37, 38 weeks of life, and then a few weeks later, if they're going to get a colicky baby, that can be, you know, there's a lot of stress around, you know, having an extreme prem baby go home, and all, and you know, all the anxieties around looking after prem babies. And then it's, if you've got, you know, they've gone home and within 2 weeks the baby started getting very, very unsettled and crying a lot, that can create a lot of anxiety. There doesn't seem to be any association with birth order, as in it's not more common in firstborns, but interestingly, firstborns are more likely to be presented to health professionals for obvious reasons. There seems to be a male and female equivalence. And as we'll all be aware, it tends to peak in the evenings, but that's in normal babies as well as in the colicky babies as well. So it's that sort of, you know, the crying hour around dinner time, when, you know, mum or the primary caregiver is very tired of looking after the baby, and you've got to try and get the evening meal sorted out, and that tends to be when the babies are crying the most.
Is there like a certain time when you guys would suggest a diagnosis of colic? I mean, in weeks? I feel like it's a massive peak, yes.
But I think the most important thing is reiterate is the history. So getting it, so you want to say, when did the crying start? How old was the child? Is it reaching the peak at the right time? The other thing is that they do tend to sleep well when they do get off to sleep. So whereas if there's other sort of organic reasons for unsettled or crying babies, they don't form in that same pattern. So that's why history is very important. They've settled in the first few weeks. Around 2 or 3 weeks, they start to increase in their crying. They're reasonably settled during the day, but the frequency and duration of crying increases across the day. It's worse in the evening, and they can, you know, be crying for an hour or so. But then they tend to fall asleep and then have a reasonable sleep, and then the cycle starts again the next day. Whereas babies with things like reflux and things, they will cry all the time, or associated with feed. So it's that sort of real pattern of crying that's important when you're taking a history. There doesn't seem to be a particular association between formula or breastfed infants with colic. And there is some suggestion that older and better educated mums, I think they're more likely to present with, you know, for help. There's no suggestion that there's an increased amount of crying or prevalence in that group. And so the other thing is this a Western disease? Is the way we sort of living is making babies more unsettled and colicky in general? So there was some research done in other ethnic groups, and this Kung Sang group, which are basically a hunter-gatherer tribal group in Botswana, and they looked at the crying pattern of infants in this group, and so it wasn't just recall either. They would have like I am mic'd up, and they'd actually record how long the babies were crying for, so they could quite accurately determine how long and often the babies were crying. And so the hypothesis, is are the crying patterns of infants innate, and will they be similar irrespective of their child rearing practices? In this group, the babies were sort of kangaroo cared in a sling, and they were carried all the time, held upright, fed on demand, and were responded to immediately. And what do people think about the likely? Are they going to be the same or different to? Different? Pretty much the same. Not quite. They didn't cry. It wasn't quite as pronounced, but they had a very, very similar time frame to their crying. So it seems that there is a subgroup of babies who are susceptible, despite child rearing practices, which will have this sort of colicky crying pattern. So the increasing time of carrying or the kangaroo care reduces in a small reduction in the time of crying. And there's been a number of other, they're relatively old, but a number of other studies which have found similar pattern. And I just want to point out, this is just some, you probably can't see that, but the incidence of shaken baby syndrome, this is on some US data. And that follows a similar, there's about a 6-week lag period between that. And often when babies are presented with the diagnosis of shaken baby syndrome, there's good evidence it's not the first time that the baby's been injured. And you can see there is more likely a correlation between these two graphs. So if you could sort of intervene in here and try and prevent that, that's obviously what we're trying to do. So just that there is evidence that colicky babies are different, that they seem to be physiologically different. They're a relatively smaller subgroup, but they seem to be respond in a different way to their environment, and that they have excessive crying. The theory is it's possibly related to a poorer recruitment of an opioid-driven soothing process, with the failure on adequate production of endogenous opioids, or that they've got an end organ receptor issue. And I think just giving advice to the families around these patterns of crying, it can be reassuring to them. And so you need to reassure parents that there's nothing wrong with their infant, that the babies do fine. And there aren't very many good sort of long-term follow-up studies looking at sort of colicky babies, because are they more susceptible to other conditions when they grow up? If they're sort of physiologically a bit different than other children, are they more susceptible to other things? And there hasn't been any real consistent sort of data on that, and the relatively small studies. This one 10-year follow-up study found a slight increase in the risk of recurrent abdominal pain, allergic disorders, and some behavioural disorders. But it's quite a small study. A slightly larger study with around a 10% infantile colic didn't confirm any association with allergic conditions. But we do know that the parents of these infants can have, they can struggle to cope with these babies. So if it's more difficult to form an attachment to a baby that's crying all the time, there seems to a lot of poor self-esteem because there's something that they're not doing right, which is making the baby cry, that they're an incompetent parent because their baby's in distress and they just don't know what to do, and if only they knew what to do, the baby would be better. So I think it's about reassuring parents that that your baby is a bit different. It seems to be the smaller subgroup of babies who just find it more difficult to settle.
Baby seats, going back to the baby seats are quite popular, the idea that it's soothing.
Yeah.
But I'm worried about the whole, the whole property that making instruction. I mean, the baby is a feaster thing, that's not quite, but it's basically sleeping on its chest tube. It looks like a whole way that eating has to do with
Yeah, that's right.
It's very popular, but I'm sort of worried.
Yeah. I think particularly in the first few weeks as well, when they haven't got very good head control, so you can get sort of obstruction. Even sitting in car seats, particularly the more upright seats, that the head tend to drop, and I've seen a number of.
Description that all that's what everything want to do, and it's natural, and sort of feel good things, and the baby's close to you, it feels good, but I do actually wonder.
I think you've just got to be cautious about the position as well. I think if they're too upright and they're crumped, then they can obstruct. That's right. So I think the parents do need a lot of support around that.
I imagine, especially for people who are trying to do that, who are not as experienced at upright carrying.
No, that's
right. It's an innate behaviour. It would be interesting. Well, cultural behaviour. Interesting to see what their.
I think if you get the sling,
It's quite hard to do that carrying baby.
Yeah.
And so Dr. Barr came up with this sort of purple crying anagram with so you've got the peak pattern, so it's sort of peaking in that first sort of month to 6 weeks. The sort of unpredictability of the crying, that they're hard to settle, that they do look to be more in pain, and they cry for longer, and there's that predilection for the crying in the evening. And just the concept that it's a behaviour. The colic is a behaviour rather than a medical condition. And so there's been obviously there's been a number of attempts to provide some therapies for infant colic, and none of them are of particularly proven value. There's been some studies looking at mums going onto a low allergen diet, so the suggestion of whether this could be, babies being sensitized by some of the proteins in the mum's diet, and so going onto a sort of a low allergy diet, and that hasn't been consistently shown to be an effective treatment by any means, and there's now some evidence that you could then put the infant at increased risk of becoming sensitized subsequently, because we're now starting to be aware that delaying exposure to a lot of food proteins in infants can increase the infant's risk of becoming sensitized to foods. So I think you just have to be quite cautious about that. Again, that's when your history comes in, that if you're thinking it might be sort of food protein allergy, then you'd be looking for other physical or history, things in the history which should suggest that. So a different pattern of crying, they might be irritable a lot of the time, irritable around feeds, they might have altered bowel habit, and plus or minus eczema, things like that. So you'd be looking for other characteristics in the baby's behaviour to suggest there's some other underlying process, like a food protein allergy. And they've tried a number of, and as I say, it's often around, thinking this is gut in origin when there's no particular evidence for that. So they've tried antacids, a number of different colic remedies can contain various degrees of these different things, but to be honest, there's nothing of any proven value. Seems to be the amber beads are the flavour of the year. And there's not a clinic goes by that I don't see a baby with amber beads, but so I think the best strategy is to describe the natural history, reassure that the infant is healthy, and we'll talk about that in the next part of the talk, because some babies cry because they do have something wrong with them. So I don't want you to go away from the session thinking that all babies are crying and just have infant colic, and they're going to get better. But if you've taken a good history and examined the infant and the baby's otherwise doing well, and the crying pattern is similar to what we've described, then they're all likely to be reassuring things. I think the most important thing is that the families get some support, particularly the primary caregiver gets some time out from the crying baby. So you need to get the rest of the whānau around these difficult babies, because the parents need a lot of extra support, and particularly around the risks of to the infant if the parents are really struggling to look after these babies. And then they end up like that at about 18 weeks. Hold on. Was there any questions around the sort of colicky crying behaviours?
I'm quite interested in the use of sugar to soothe the baby.
Yeah, well, it's
because of our obesity epidemic.
Right. Yeah, well, we use it obviously just around painful procedures. So we're not advocating it to be used, by parents at home for quiet baby, for unsettled babies to try and quiet them. Yeah, so that's a good point. It's analgesia for a painful procedure, so that's why that's been looked at. So I suppose there's this sort of physiological response to feeding, and this, so you've got a sensor in the mouth for sugar, and then you get an endorphin release, and that, I think that's why babies want to feed, and then they get that satiety from feeding.
I suppose I'm thinking of not very good healthy eating patterns being determined at a very early age.
Yeah, could you trial
go for sugar?
Go for sugar.
Have you already?
Yeah, the thing with particularly if you're doing painful procedures and they've got a full stomach, then that there's potential they can vomit and aspirate and things, and it's quite a small volume. It's purely around, as I say, the looking at crying behaviours and analgesic. So it's more effective than and a quick onset of action as well. The higher concentration of the glucose, so it seems to have a better analgesic effect than a feed. But this, as I say, this is for like analgesia for putting a drip in or a painful procedure that we do in the neonatal unit.
How much do they need? It's just
Yeah, that's right. It's a small volume, and you just put it in buccally, so it's a small volume and it just gets absorbed.
Usually about 5 children, so it's a tiny amount.
So I just want to talk a little bit about potentially or organic causes for babies being unsettled and crying, and often when babies come along to the paediatric outpatients, they've been to see the GP, and then they've been referred on, and often have already been treated for gastroesophageal reflux. So any baby that seems to cry excessively is at risk of being diagnosed of gastroesophageal reflux. So thought it's useful just to talk a bit about this condition and trying to distinguish between the two and how we can manage true gastroesophageal reflux. So it's defined as the retrograde passage of gastric contents into the esophagus, and we talk about gastroesophageal reflux disease if there's a symptom or complication of this. So the baseline lower esophageal sphincter pressures are normal in infants, but you get reflux when you get frequent relaxations of this sphincter. It's promoted in young babies or infants because they're on basically a liquid diet, and they've got relatively small stomachs, and so every few hours that they're filling their stomach up with liquid, and they're often lying down or in slumped positions. So all of these things are setting the baby up to have reflux. Reflux is a very common condition. Virtually all infants will vomit at least once during the first week of life, and sort of 2/3 of them can vomit following one feed a day at around 3 or 4 months of age. So spilling or vomiting is not an abnormal behaviour. It tends to improve by about 6 months, and then in the majority by sort of 10 to 12 months the reflux is settled. So again, understanding the natural history is important. So what is pathological? So we look at the number and severity of episodes, what symptoms or complications can be associated with the reflux. And so if there's a child where you're thinking, could this unsettled baby have gastroesophageal reflux, you need to look at the feeding history. So how often are they feeding? Are they formula or breastfed? Positioning, ability to latch on, and their effectiveness of their feeding. So and directly observing them during a feed is important, particularly that they're not swallowing excessive air if they're not getting a decent latch, or potentially with a tongue tie. With the vomiting, you want to obviously take a history around how often the baby's vomiting. Is it, what proportion of their feed? Is it seem to be all of their feed? Is it very forceful? Is it associated with discomfort? And more concerning, particularly bile, if there's any baby that has a green vomit, needs to be, it's a medical emergency if they have a green vomit, because they've got a bowel obstruction until proven otherwise. So sort of one of those greens on the wall there. Anything resembling that painting over there, you need to be reviewed medically. And there's a number of different things that can cause a bowel obstruction in a baby, and particularly malrotation, and that's where you get an abnormal positioning of the small bowel, and it can have like we call a volvulus, where it twists on an abnormal mesenteric stalk, and that can be intermittent. So the baby just presents with bilious vomiting, and the baby may look completely normal in between times. It doesn't have to have abdominal distension, or so that history of episodic bilious vomiting is a concerning thing in a newborn. And they can twist and actually infarct their bowel if it's left untreated. And there are a number of other different causes of bowel obstruction. Obviously hernias, it's always important to look for a hernia in a little baby who's vomiting. And girls can get hernias, obviously not as often as boys, but don't forget to look in the groin of the baby girls for any little bulge. They can actually get an ovarian hernia as well. So in your family history, is there any history of sort of food allergies, or if the infant is formula fed, and there are other things, as I say, like altered bowel habit or sort of rashes, eczema. Could the baby have a cow milk protein intolerance? There are some rarer metabolic conditions which can be associated with increasing frequency of vomiting, because they don't metabolize the protein as well in some conditions, and so that can be associated with failing to thrive and vomiting. The social history, so how the family are coping and what supports they've got, and whether there are other potential issues which may be contributing to the vomiting from the past medical history. As paediatricians, we're always obsessive about plotting growth, and I'm sure you guys all are as well. And it's a very reassuring to see a nice, healthy growth chart. And alarm bells always ring if babies are, falling away from their growth centiles. But having said that, babies in that first few months often do cross some centiles. Their birth weight is often determined by the placental function, and then over that first sort of six to 8 months, that they can then go on to find their genetic growth centile and then follow that. The difficulty is in that first 6 months when the baby's crossing some centiles, is that because there's something pathological there, or is it that they're just finding their new centile? Looking for eczema to see whether there could be that association with the cow milk protein intolerance. Abdominal distension is always a concern, whether there's that could be if there's obstruction. Sometimes if they're not absorbing, if they're getting like a malabsorption syndrome for various reasons, then they can get abdominal distension, and that's usually sort of some of the sugars which aren't absorbed, which then ferment and cause extra gas. Or we can see it in things like Hirschsprung's disease, where so that's a baby who'd be constipated, and possibly having that delayed passage of stool in the first 24 hours of life is a characteristic of Hirschsprung's. So a baby who had infrequent bowel movements, abdominal distension and episodic vomiting, then you need to sort of consider Hirschsprung's as a possibility. Talked about checking for hernias. And we know that neurologically impaired infants are more prone to reflux, and so the children who subsequently could develop things like cerebral palsy are a lot more prone to reflux and difficulty with their feeding. So that's obviously but if you've got a floppy baby as well, that could be an early sign that they've got some neurological impairment, which could be associated with their spilling or feeding difficulties. So the things that you look for the symptoms of gastroesophageal reflux, that the sort of irritability and crying can often be associated with the feeding. So the concept that they've got esophagitis there, that their gullet is inflamed because of the acid reflux. So then they associate feeding with discomfort, and that can lead to babies not wanting to feed as well, because they quickly learn that when they feed, they've got heartburn or discomfort, and they can have a poor sleep pattern. Some babies who spill a lot just don't grow properly. They don't keep enough of their feed in to allow them to grow adequately, and that's a sign that we would then be considering medical treatment of reflux if they were failing to grow properly. We see some infants that come in the first few months of life with what we call an ULTI, or an apparent life-threatening event. And these infants, they look as if they're going to die, is one of the definitions. So they can look very pale, go quite floppy and apneic, and can be associated with apneas or bradycardias. and these episodes can be associated with reflux. So that when you get acid contents of the stomach going up into the even into the lower esophagus or into the larynx, that babies can have a reflex to stop breathing, and they can have a laryngeal spasm and get an obstructive event, and then they can go quite floppy after that event. And it's thought to be a developmental thing so they stops them from aspirating if they've got sort of acid milk in the back of their throat. But there's obviously these kids come into hospital and we do a number of investigations, because there can be, you know, a number of medical things that can cause this, like seizures or metabolic conditions or cardiac arrhythmias or seizures. So we've got a bit of a differential to work through, but not infrequently we don't find necessarily a cause for an ALTI, and then we sometimes do, which I'll describe in a bit, doing the pH monitoring to look into whether some events which you're not sure could be reflux related, is that those events actually associated with reflux.